Hematology Chapter 3 Hematopoiesis. Hematopoiesis is the production of blood cells and platelets which occurs in the bone marrow. It begins in embryonic life in the mesoderm of the yolk sac. During the second month of gestation, it moves to the liver. At approximately month 7 of gestation, it moves to the marrow of the bones. After birth, there is a progressive restriction of productive marrow to the axial skeleton and proximal ends of the long bones. It begins with the multipotential hematopoietic stem cell. Multipotential meaning it can become anything. It's capable of proliferation, replication, and differentiation. It's also known as the hemocytoblast. It can become either the common myeloid or the common lymphoid progenitor. The common myeloid progenitor can become a granulocyte, a monocyte, an eosinophil, a basophil, a megakaryocyte, and an erythrocyte. The common lymphoid progenitor can become a dendritic cell, a pre-B cell, a pre-T cell, or a natural killer cell. Precursor cells start at blast formation, which is the stage before mature cells in the peripheral blood. The peripheral blood cells are erythrocytes, which are red blood cells, lymphocytes, basophils, eosinophils, monocytes, segmented neutrophils, and platelets. As cells mature to erythrocyte, they grow through the phases pronormoblast, which is also known as a rubriblast, basophilic normoblast, which is also known as a prorubrocyte, a polychromatophilic normoblast, which is also known as a rubrocyte, an orthochromatic normoblast, which is also known as a metarubrocyte, and a polychromatophilic erythrocyte, which is also known as a reticulocyte, before finally becoming mature erythrocytes. Myelopoiesis, or granulocytopoiesis, is the production of neutrophils, eosinophils, and basophils. It goes from blast to mature cells, which is a process that can take 7 to 11 days. It starts with myeloblast, then promyelocyte, then neutrophilic myelocyte, then metamyelocyte, then band, and then segmented or polymorphonuclear. Eosinophil maturation begins with a myelocyte, then metamyelocyte, then band, and then segmented eosinophil. All eosinophils have abundant secondary or specific granules in the cytoplasm. These are reddish-orange granules or salmon-colored. Their nuclear morphology matures the same as a neutrophilic granulocyte. Basophilic maturation begins with a myelocyte, then a metamyelocyte, then a band, and then a basophil. All basophils have predominant primary granules in the cytoplasm, or large purple granules. Nuclear morphology follows the same pattern as eosinophils and neutrophils. Monopoiesis begins with monoblast, then promonocyte, then monocyte, and then macrophage. Lymphopoiesis begins with a lymphoblast, then a prolymphocyte, and then a lymphocyte. Plasmacytes, or plasma cells, represent the end stage of B lymphocyte lineage. Cytoplasm is non-granular and usually stains a deep or vibrant blue. Cytoplasm adjacent to the nucleus is pale with a perinuclear clear zone containing the Golgi apparatus. One or several small vacuoles may be observed. The nucleus is relatively small, round, or oval and eccentrically placed in the cell. Nuclear chromatin is clumped or coarse and lumpy, similar to that of a lymphocyte. The megakaryocyte is the largest hematopoietic cell in the bone marrow. They proliferate and then fragment their cytoplasm into platelets. They contain an abundant amount of pinkish cytoplasm and a multilobulated nucleus. They are 30 to 100 micrometers. After maturation is completed, the megakaryocyte membrane ruptures, the entire megakaryocyte cytoplasm fragments, and thrombopoiesis occurs. The polyploid naked nucleus is soon to be engulfed by a macrophage. Whole blood is the average blood volume. The average blood volume in an adult is 4 to 6 liters. Parts of whole blood are formed elements such as red blood cells, white blood cells, and platelets, and plasma, which is water of about 92%, protein about 7%, and solutes, which are around 2%. Blood is composed of 55% plasma, the liquid portion, and 45% cells, or the formed elements. Chapter 3 from the book: Red blood cell production, function, and relevant red blood cell morphology. Key terms: anaerobic, or able to live without oxygen; artifact, anything artificially produced; asynchrony, or failure of an event to occur at the same time; cytoskeleton, internal structure framework of the cell; disseminated intravascular coagulation, or pathologic condition in which the coagulation pathways are hyperstimulated, either excessive clotting or excessive bleeding; pancytopenia, or reduction of all cellular elements, white blood cells, red blood cells, and platelets; pathology, or the study of nature and cause of disease that involves changes in structure and function; splenectomy, or removal of the spleen; and thrombi, the plural of thrombus, a blood clot that obstructs a blood vessel or cavity of the heart. Basic red blood cell production. Red blood cell production is a dynamic process that originates from pluripotent stem cells. Stem cells are phenomenal structures that can give rise to many tissues, including skin, bones, and nerve cells. Next to the mapping of the human genome, the use of stem cells as therapeutic agents is one of the paramount discoveries of the 20th century. What makes stem cells so appealing is their versatility. They respond to a programmed chemical environment in bone marrow or in cell culture, replicating and eventually producing the tissue that corresponds to their chemical menu. Red blood cell production is controlled by erythropoietin, or EPO, a low molecular weight hormone produced by the kidneys and dedicated to red blood cell regeneration. EPO travels through the circulation and locks onto a receptor on the pronormoblast, the youngest red blood cell precursor, stimulating it to produce 16 mature red blood cells. Red blood cell maturation. Mature red blood cells are one of the few cellular structures in the human body that begin as nucleated cells and become anucleate. This remarkable development occurs in the bone marrow over 5 days as each precursor cell goes through 3 successive divisions, yielding smaller and more compact red blood cells. There are 6 stages of maturation in the red blood cell series: pronormoblast, basophilic normoblast, polychromatophilic normoblast, orthochromic normoblast, reticulocyte, and mature red blood cell. The kidneys act as a gauge of tissue hypoxia, secreting more EPO when necessary to increase red blood cell production. In the bone marrow, erythrocytes seem to cluster in specific areas, the so-called erythroblastic island, which is easily identified in the bone marrow aspirate by a distinct morphology: extremely round nuclear material combined with basophilic cytoplasm. The main site of erythropoiesis in adults is the bone marrow, located within the sternum and iliac crest. In children, erythropoiesis takes place in the long bones and sternum. Features of red blood cell development. Each red blood cell maturation stage is described using size, or N to C ratio, which involves the amount of nuclear material in the cell relative to the cytoplasm content, nuclear chromatin characteristics, and cytoplasm descriptions. Identification of immature red blood cells should be systematic and based on reliable morphologic criteria. In general, several morphologic cues mark the red blood cell maturation series as follows. When the red blood cell is nucleated, the nucleus is baseball round. There are no granules in the cytoplasm of red blood cells. The cytoplasm in younger cells is extremely basophilic or blue-toned and becomes more lavender-tinged as hemoglobin is synthesized. Overall cell size decreases as the cell matures. Nuclear chromatin material becomes more condensed in preparation for extrusion from the nucleus. Nuclear chromatin is described with respect to chromatin distribution, chromatin texture, and color. The N to C ratio decreases as the nuclear material becomes more condensed and smaller in relationship to the entire red blood cell. The N to C ratio is the ratio of the amount of the nucleus to the amount of cytoplasm present. The higher the N to C ratio, the more immature the cell. In the bone marrow and in the peripheral smear, each of these clues is helpful in enabling the technologist to appropriately identify the maturation stage of a particular red blood cell. Red blood cell membrane development and function. The mature red blood cell is a magnificently designed instrument for hemoglobin delivery. As a hemoglobin-filled sac, the red blood cell travels more than 300 miles through the peripheral circulation, submitting itself to the swift waters of the circulatory system, squeezing through the thread-like splenic sinuses, and bathing in the plasma microenvironment. Cellular and environmental factors contribute to red blood cell survival. For the red blood cell to survive for its 120-day life cycle, the following conditions are necessary. The red blood cell membrane must be deformable, able to squeeze through smaller diameter blood vessels. Hemoglobin structure and function must be adequate. The red blood cell membrane must maintain osmotic balance and permeability. The mature red blood cell is an anucleate structure with no capacity to synthesize protein, but it is capable of a limited metabolism that enables it to survive for 120 days. An intact, competent, and fully functioning red blood cell membrane is an essential ingredient to a successful red blood cell lifespan. The membrane of the red blood cell is a trilaminar and three-dimensional structure containing glycolipids and glycoproteins on the outermost layer directly beneath the red blood cell membrane surface. Cholesterol and phospholipids form the central layer, and the inner layer, the cytoskeleton, contains the specific membrane proteins, the spectrin, ankyrin, actin, and protein. Composition of lipids in the interior and exterior layers. 50% of the red blood cell membrane is protein, 40% is lipid, and the remaining 10% is cholesterol. The lipid fraction is a two-dimensional interactive fluid that serves as a barrier to most water-soluble molecules. Cholesterol is equally distributed through the red blood cell membrane. However, plasma cholesterol and membrane cholesterol are in constant exchange. Cholesterol may accumulate on the surface of the red blood cell membrane in response to excessive accumulation of cholesterol in the plasma. The red blood cell becomes heavier and thicker, causing rearrangement of hemoglobin inside. This can cause the red blood cell to change its shape. Some red blood cells may form a morphology known as a target cell. Additionally, red blood cells may form acanthocytes, owing to the cholesterol depositions in patients with liver disease and lecithin cholesterol acetyltransferase, or LCAT deficiency. The cytoskeleton, peripheral proteins. The third layer of the red blood cell membrane, the cytoskeleton, is an interlocking network of proteins that supports the lipid bilayer and the peripheral proteins. The cytoskeleton plays a significant role in the deformability and elasticity of the red blood cell membrane. Deformability and elasticity are crucial properties to red blood cells because the red blood cell, with an average diameter of 6 to 8 micrometers, must maneuver through vascular apertures such as the splenic cords and capillary arterioles, which have diameters of 1 to 3 micrometers. Spectrin and ankyrin are peripheral proteins that are responsible for the deformability properties of the red blood cell. The intact and deformable red blood cell can stretch 117% of its surface area as it weathers the turmoil of circulation, squeezing through small spaces. Inherited abnormalities of spectrin can lead to the production of spherocytes, a more compact red blood cell with a reduced lifespan. Spectrin-deficient red blood cells are normal in size before they exit the bone marrow. It is only when they are pushed into the systemic circulation and subjected to the rigors of the spleen that the outer layer of the red blood cell membrane is shaved, leading to a more compact and damaged cell, the spherocyte. This particular spherocyte mechanism best illustrates the progressive loss of membrane that occurs in hereditary spherocytosis. When the spherocyte is reviewed by the spleen, the membrane is removed, leaving a remodeled red blood cell. Other mechanisms for the formation of spherocytes may occur, and these are discussed later. Red blood cell metabolism. Because the mature red blood cell is an anucleate structure, it has no nuclear or mitochondrial architecture for metabolizing fatty or amino acids. Consequently, it derives all its energy from the breakdown of glucose. 3 metabolic pathways are essential for red blood cell function, as follows. The Emden-Meyerhof pathway provides 90% of cellular ATP because red blood cell metabolism is essentially anaerobic. The functions of ATP are multifactorial and include maintenance of membrane integrity, regulation of the intracellular and extracellular pumps, maintenance of hemoglobin function, and replacement of membrane lipids. This pathway also generates the oxidized form of nicotinamide adenine dinucleotide, or NAD+, from the reduced form of nicotinamide adenine dinucleotide, or NADH, an important structure in the formation of 2,3-diphosphoglycerate, a key element to oxygen loading and unloading. The phosphogluconate pathway, or hexose monophosphate shunt, provides 5 to 10% of the ATP for the cell. This is necessary so that reduced nicotinamide adenine dinucleotide phosphate, or NADPH, is produced and globin chains are not degraded when subjected to oxidative stress and the accumulation of hydrogen peroxide. If this pathway is deficient, globin chains may precipitate, forming Heinz body inclusions in the red blood cell. Heinz body inclusions lead to the formation of bite cells in the peripheral blood as Heinz bodies are pitted from the cell by the spleen. The methemoglobin reductase pathway maintains iron in the reduced ferrous state, or Fe2+, so that hemoglobin can bind oxygen and deliver it to the tissues. This pathway is dependent on the reduction of NAD+ to NADH. If this enzyme is absent, methemoglobin accumulates in the red blood cells. Oxygen transport capabilities are seriously impaired because methemoglobin is a form of hemoglobin in which iron is the reduced state and cannot combine with oxygen. Abnormal red blood cell morphology. Automated instrumentation in hematology has redefined the level of practice in most hematology laboratories. Along with the complete blood count, most instruments offer an automated differential count, a procedure where 100 white blood cells are identified on a peripheral smear. When values from the differential or CBC are out of the reference range, results are flagged. Consequently, the operator or technologist must make a decision to perform reflex testing and possibly review a peripheral smear to resolve any abnormal results. Most peripheral smear reviews are performed on patients who are seriously ill or have multiple pathologies. For this reason, proficiency in identifying normal and abnormal red blood cells is a valuable skill, one that must be practiced as a student and maintained as a professional. This section concentrates on defining abnormal red blood cell morphologies and the pathologies that cause them. Automated cell counting and differential counters have not yet replaced the discriminating eye with respect to the subtleties of red blood cell morphology. When reviewing peripheral smears for red blood cell morphology, it's important to consider the following. Is the morphology distributed throughout the slide or seen in only one field or area? Is the morphology artificial, like caused by a slide-making procedure, or pathologic, like caused by the patient's condition? It is important to gain an overall impression of red blood cell distribution before specifically identifying morphologies. Technologists do this by scanning well-stained and well-distributed fields in a peripheral smear and making a judgment about whether anisocytosis, or variation in size, and poikilocytosis, or variation in shape, are present. If these are present, technologists proceed to record and quantitate the specific sizes and shapes seen. Platelet morphology and the presence of nucleated red blood cells may also be observed. The majority of institutions use qualitative remarks or a numerical grading system or a combination of both to grade the specific morphology. Numeric procedures for assessing red blood cell morphology are explained in Chapter 21. In a complete review, 10 fields are observed. However, there are times when observation of fewer cells is appropriate. A careful inspection of a patient's red blood cell landscape can provide morphologic clues as to the pathology of the patient's condition, leading to proper treatment and restoration of hematologic health. There is no substitute for a well-distributed, well-stained peripheral smear when assessing red blood cell morphology. Variations in red blood cell size. A normal red blood cell is a disc-shaped structure that is approximately 6 to 8 micrometers and has a mean corpuscular volume, or MCV, of 80 to 100 FL and a mean corpuscular hemoglobin content, or MCHC, of 32 to 36%. Variations in size and color should correlate with these indices from the CBC report. Variations in size are seen as microcytes, or less than 6 micrometers, or macrocytes, greater than 9 micrometers. Microcytic cells evolve from 4 main clinical conditions: iron deficiency anemia, thalassaemic syndromes, sideroblastic anemias, and anemia of chronic disorders. Microcytic cells have cells less than 80 FL and are most often seen in iron deficiency anemia, a frequent clinical condition that results from impaired iron metabolism caused by either deficient iron intake or defective iron absorption. Iron is an essential element to the formation of the hemoglobin molecule. Iron needs to be absorbed from the bloodstream and transferred via transferrin to the pronormoblasts of the bone marrow for incorporation into the 4 heme structures of each hemoglobin molecule. Iron-starved red blood cells searching for iron divide more rapidly than normal red blood cells, and they are smaller because of these rapid divisions. Thalassaemic conditions also give rise to microcytes owing to decreased or absent globin synthesis. When either alpha or beta chains are missing or diminished, normal adult hemoglobin is not synthesized, and hemoglobin configuration is impaired, leading to microcytic cells that have an increased central pallor known as hypochromia. Iron overload disorders such as hereditary hemochromatosis or sideroblastic processes show a dimorphic blood smear. Some microcytes caused by inflammation also exhibit microcytes because iron delivery to their reticuloendothelial system is impaired. Immature red blood cells are nucleated structures, and nuclear synthesis depends on vitamin B12 and folic acid. If either of these vitamins is unavailable or cannot be absorbed through the gastrointestinal system, a macrocytic cell evolves because fewer cell divisions are made. More information concerning vitamin B12 and folic acid is available in Chapter 6. Macrocytic red blood cells have an MCV that exceeds 110 FL and a diminished lifespan. This causes a megaloblastic anemia, which is when erythropoiesis is ineffective within the bone marrow because the red blood cell precursors are prematurely destroyed before they are released into the peripheral circulation. Additionally, an asynchrony develops, an imbalance between the nuclear structure and the cytoplasm. The nuclear age appears to be out of sync with the cytoplasm development. A pancytopenia is noted in the CBC of megaloblastic patients, and peripheral smears reveal hypersegmented neutrophils and macroovalocytes. Individuals with alcoholism and/or liver disease may have a borderline increased MCV and large red blood cells. An increase in MCV may also result from high reticulocyte counts where polychromatophilic macrocytes are seen in the peripheral smear. Variations in red blood cell color. Color variations in red blood cells are observed as polychromasia or hypochromia. Polychromasia is often seen in response to anemic stress when there is excessive production of red blood cell precursors in response to anemic stress. When the bone marrow responds to anemic stress, it releases reticulocytes and sometimes orthochromic normoblasts, or nucleated red blood cells, prematurely. In the peripheral smear, increased polychromasia, red blood cells that are gray-blue and larger than normal, is seen. Polychromatophilic macrocytes are actually reticulocytes. However, the reticulum can be visualized only when these cells are stained with supravital stain, such as new methylene blue. The presence of polychromasia is an excellent indicator of bone marrow status. Hypochromic red blood cells exhibit a larger than normal area of central pallor, and are usually seen in conditions in which hemoglobin synthesis is impaired. Most hypochromic cells have an MCHC of less than 32%. The development of hypochromia is usually a gradual process and can be seen on the peripheral smear as a delicately shaded area of hemoglobin within the red blood cell structure. Any starkly defined area of red blood cell pallor is usually artifactual and not true hypochromia. Not all hypochromic cells are microcytic, but all microcytic cells are hypochromic. Hypochromia of varying degrees can be seen in iron deficiency anemia, in thalassemic conditions, and in sideroblastic processes. Variations in red blood cell shape. Variations in the shape of red blood cells are always linked to a red blood cell pathophysiology. Abnormal red blood cell morphology presents the laboratory professional with visual clues for possible causes of the patient's hematologic problems, whether it is decreased red blood cell production, increased destruction, or defective splenic function. 5 distinct morphologies are discussed. Although these are not all-inclusive, they represent the most common abnormalities seen in a metropolitan population. Spherocytes. Spherocytes are compact red blood cells with a near-normal MCV and an elevated MCHC, usually greater than 36%. They are easily recognized among the rest of the red blood cell background on the peripheral smear because they are dense, dark, and small. Spherocytes arrive in the peripheral circulation via 3 distinct mechanisms. The first mechanism involves individuals who have hereditary spherocytosis, which results from inherited spectrin abnormalities. Mature red blood cells in patients with HS arrive in the peripheral circulation with a normal appearance, but as the cells try to negotiate the splenic sinuses, the spleen senses the membrane imperfections and shears the exterior membrane, leaving a more compact but osmotically fragile structure, the spherocyte. The restructured red blood cell has a reduced lifespan, and the patient has a lifelong moderate anemia. Second, aging red blood cells lose pieces of their membrane during senescence as part of natural red blood cell death. Because red blood cells pass through the spleen hundreds of times during their 120-day life cycle, older and less perfect red blood cells are trapped by this organ and rendered as spherocytes, where they are eventually removed by the reticuloendothelial system. The final pathophysiology producing a spherocyte involves the formation of antibody coating of red blood cells, which can occur following an autoimmune or immune process. As antibody-coated red blood cells percolate through the spleen, the antibodies are removed, resulting in small amounts of the red blood cell membrane being lost. This causes the red blood cells to change shape to a spherocyte. Sickle cells. Sickle cells are a very distinct red blood cell morphology with a crescent shape and pointed projections at one of the terminal ends of the red blood cell. Individuals with sickle cells have sickle hemoglobin, or hemoglobin S, as one component of their adult hemoglobin complement. Sickle hemoglobin is an abnormal hemoglobin, and red blood cells containing hemoglobin S homozygously have a dramatically reduced lifespan. Hemoglobin S is intractable and forms tactoids under conditions of hypoxic stress. When red blood cells containing hemoglobin S try to maneuver through the spleen and the kidney, the hemoglobin lines up in stiff bundles. This makes the red blood cell less elastic and unable to squeeze through the microcirculation of the spleen. The cell deforms, takes the sickle shape, and is permanently harmed. Many sickle cells may revert to normal disc shape when properly oxygenated, but approximately 10% are unable to revert. These are labeled as irreversible sickle cells. Reversible sickle cells appear in the peripheral smear as thicker, more rounded, half-moon-shaped cells with no pointed projections. Sickle cells may appear in combination with other hemoglobin-related disorders, such as hemoglobin SC and hemoglobin S thalassemia. Stomatocytes. Stomatocytes appear with elongated areas of central pallor, approximately 3/4 diameter of the red blood cells. Several chemical agents, such as phenothalazine and chlorpromazine, can induce this morphology. The osmotic fragility of these cells increases owing to the elevated sodium intake through the red blood cell membrane. These structures are often created artifactually through pore slide technique and can be distinguished from true stomatocytes by their more defined outline. Genuine stomatocytes are shaded within the hemoglobin of the red blood cell and can be seen in the Rh null phenotype, in hereditary stomatocytosis, and in some alcoholic conditions. Ovulocytes and elliptocytes. Ovulocytes and elliptocytes are red blood cell morphologies that are often used interchangeably, yet these two distinct morphologies have several recognizable differences. Ovulocytes are egg-shaped and capable of many variations of hemoglobin distribution and size. These cells may appear macrocytic, hypochromic, or nomochromic. Ovulocytes, more specifically macroovulocytes, may be observed in the megaloblastic processes. Normochromic ovulocytes are typically seen in thalassemic syndromes. Elliptocytes are a distinct morphology derived from abnormal spectrin and protein 4.1 component, both red blood cell membrane proteins. In hereditary elliptocytosis, elliptocytes are the predominant morphology, yet this condition is fairly benign with little consequence to the red blood cell. The two other genotypes of this order, hereditary pyropoikilocytosis and spherocytic hereditary elliptocytosis, are a much more serious morphology with severe anemia. They are discussed in Chapter 7. Elliptocytes may also be present in the peripheral smear of iron-deficient individuals and patients with idiopathic myelofibrosis. Target cells. Target cells appear in the peripheral smear as a bullseye-shaped cell. They are seen in the peripheral blood owing to three mechanisms. 1. As an artifact in slide making. 2. Because of decreased volume secondary to loss of hemoglobin. And 3. Because of increased red blood cell surface membrane. As cholesterol increases in the plasma, the red blood cell surface expands, resulting in increased surface area. Target cells appear as hypochromic, with a volume of hemoglobin rimming the cells and a thin layer of hemoglobin located centrally, eccentrically, or as a thick band. As a morphology, target cells appear in iron deficiency anemia, hemoglobin C disease, and associated conditions, and liver disease after a splenectomy. When hemoglobin is effective qualitatively, target cells appear. Acanthocytes. Acanthocytes represent a peculiar red blood cell morphology that is marked by a smaller-sized red blood cell surrounded by uneven thorn-like spicules projecting from the red blood cell surface. Spicules can range in number from 3 to 9 and are varied in size and thickness. A similar morphology exists, known as the Burr cell, in which even projections arise from the red blood cell surface. Care should be taken to avoid confusing the two. Features of acanthocytes include excess cholesterol, increased surface area, and decreased lecithin. Consequently, acanthocytes may appear in liver disease, autoimmune hemolytic anemia, McLeod syndrome, or lack of KEL antigens, and lecithin cholesterol acyltransferase, or LCAT, deficiency. High numbers of acanthocytes appear in congenital abetalipoproteinemia. Fragmented cells. Fragmented cells are pieces of red blood cell membranes. This morphology is a group of variant morphologies that include schistocytes, true red blood cell fragments, helmet cells, and Burr cells. Regardless of the pathophysiology, these morphologies cause anemia. Physiologic events that may cause this situation include the formation of large inclusions like Heinz bodies or the predisposition of thrombi. Heinz bodies are large inclusions that form in the red blood cell because of oxidative stress, usually in patients with glucose 6-phosphate dehydrogenase, or G6PD, deficiency. As the red blood cells try to negotiate the spleen, the inclusion is pitted from the cell, leaving a morphology known as a helmet cell. Schistocytes may be a result of thrombosis conditions such as disseminated intravascular coagulation or thrombotic thrombocytopenic purpura. They may also occur in patients with burn injuries or patients who have undergone heart valve surgery. Burr cells are usually seen in conditions of uremia or dehydration, conditions that result from a change in tonicity of circulating fluids. Additionally, Burr cells may occur in blood smears that have been forced to dry through repeated weaving in the air. Red blood cell inclusions. The cytoplasm of all normal red blood cells is free of debris, granules, or other structures. Inclusions are the result of distinctive conditions. This section summarizes 4 of the most common red blood cell inclusions: Howell-Jolly bodies, siderotic granules, Pappenheimer bodies, basophilic stippling, and Heinz bodies. Howell-Jolly bodies are remnants of DNA that appear in the red blood cell as 1 to 2 micrometer round, deep purple, non-deformable structures. They are eccentrically located in the cytoplasm and seen when erythropoiesis is rushed. Howell-Jolly bodies are thought to represent remnants of the orthochromic normoblast nucleus as it is extruded from the cytoplasm. The spleen usually pits these inclusions from the cytoplasm, but when the bone marrow responds to anemic conditions, the spleen cannot keep pace with Howell-Jolly body formation. Numerous Howell-Jolly bodies may be observed in post-splenectomy patients because the spleen is unavailable to remove inclusions from the cell cytoplasm. Siderotic granules, or Pappenheimer bodies, are seen in iron-loading processes such as hereditary hemochromatosis and iron-loading anemias after transfusion therapy. They appear as small, light purple, beaded inclusions located along the periphery of the red blood cells. Prussian blue staining is confirmatory in determining whether these inclusions are iron in origin. Consequently, these inclusions are termed siderotic granules in Prussian blue staining and Pappenheimer bodies in Wright stain. Siderotic granules may also be viewed in patients with thalassemic conditions and post-splenectomy patients. Basophilic stippling is a result of RNA and mitochondrial remnants. These remnants appear as diffusely basophilic granules located throughout the cytoplasm and are either dust-like or coarse in appearance. They are difficult to visualize in the peripheral smear without fine focusing, but red blood cells containing basophilic stippling are often polychromatophilic. Whether erythropoiesis is accelerated, basophilic stippling is likely to be found as well in individuals with lead poisoning. Heinz bodies result from denatured hemoglobin and are defined as large structures approximately 1 to 3 micrometers in diameter, located toward the periphery of the red blood cell membrane. Although they cannot be visualized by Wright stain, bites cell on the peripheral smear are evidence that a Heinz body has been formed and removed by the spleen. Staining with a supravital stain, such as brilliant crescent blue or crystal violet, may be necessary to visualize the actual Heinz body inclusion. Heinz bodies are seen in G6PD deficiency and in any unstable hemoglobinopathy, such as hemoglobin Zurich. Value of the reticulocyte count. The reticulocyte count is most effective means of assessing red blood cell generation or response to anemia. because the bone marrow can expand its production by 7 times in response to anemic stress. Reticulocytes are non-nucleated red blood cells that contain remnant RNA material or reticulum. Reticulum usually cannot be visualized by right stain. Counting and evaluating reticulocytes requires staining with supravital stains such as new methylene blue or brilliant cresol blue. On right stain, reticulocytes are seen as polychromatophilic macrocytes or large bluish cells. The normal reticulocyte rate is 0.5% to 2% in adults and 2 to 6% in newborns, owing to increased production of red blood cells. An elevated reticulocyte count or reticulocytosis is the appropriate response in anemic stress and is usually accompanied by erythroid hyperplasia in the bone marrow. EPO production increases in response to hypoxia or anemia, and premature nucleated red blood cells are usually produced. Failure to produce the expected reticulocyte increase may occur in ineffective erythropoiesis, a condition in which red blood cell precursors are destroyed before they are delivered to the peripheral circulation, or if the bone marrow is infiltrated with tumor or abnormal cells. A decreased reticulocyte count may also be seen in aplastic conditions where the production of white blood cells and/or red blood cells is seriously impaired. In any event, the level or lack of reticulocyte response is an important indicator of bone marrow function. Condensed case. At a local physician office laboratory, one technologist was performing differentials. She noticed that in every smear she reviewed, Burr cells were a prominent part of the red blood cell morphology. She began to get suspicious and considered the possibility that the Burr cells were artifactual. Burr cells can be artifactual if the blood smears that are made are forced to air dry through repeated shaking, or if the buffer used in staining is not at the proper pH. Red blood cell morphologies matched to clinical conditions. Acanthocytes. The relative clinical conditions are abetalipoproteinemia, neonatal hepatitis, post-splenectomy, vitamin E deficiency, cirrhosis of liver with associated hemolytic anemia, and McLeod syndrome. Burr cells. Relative clinical conditions are burns, gastric carcinoma, peptic ulcers, renal insufficiency, uremia, and pyruvate kinase deficiency. Ovalocytes or elliptocytes have relative clinical conditions: hereditary ovalocytosis, iron deficiency anemia, megaloblastic anemia, pernicious anemia, and iron deficiency anemia. Schistocytes are associated with burns and heart valve implants, disseminated intravascular coagulation, hemolytic uremic syndrome, thrombotic thrombocytopenic purpura, bite cells, or glucose 6-phosphate dehydrogenase, or G6PD deficiency, and renal transplant patients. Sickle cells are associated with sickle cell anemia. Spherocytes are associated with ABO incompatibility, DIC, bacterial toxins, autoimmune hemolytic anemias, blood transfusion reactions, hereditary spherocytosis. Stomatocytes are associated with alcoholism, hereditary spherocytosis, malignancies, and Rh null syndrome. Target cells are associated with hemoglobinopathies, sickle cell thalassemia, hemolytic anemias, iron deficiency, liver disease including cirrhosis, and post-splenectomy. Teardrops are associated with myeloproliferative syndromes and severe anemias. Inclusions and compositions. Howell-Jolly bodies are composed of DNA. Basophilic stippling are composed of RNA remnants. Siderotic granules or Pappenheimer bodies are composed of iron, and Heinz bodies are composed of denatured hemoglobin. Inclusions and diseases. Our rods are associated with acute myeloid monocytic leukemias. Basophilic stippling is associated with lead poisoning, arsenic poisoning, thalassemia syndromes, accelerated erythropoiesis, pyrimidine 5-nucleotidase deficiency. Cabot rings are associated with post-splenectomy and pernicious anemia. Dolly bodies are associated with infection and burn patients. Hemoglobin C is associated with hemoglobin C disease, or hemoglobin SC crystals take a gloved hand shape. Heinz bodies are associated with G6PD deficiency. Howell-Jolly bodies are associated with hemolytic anemias, post-splenectomy, megaloblastic anemia. Pappenheimer bodies are associated with acquired iron-loading anemias, post-splenectomy, thalassemia, and hereditary hemochromatosis. Toxic granulation is associated with infections, burn patients, and drug therapy. The summary points for this chapter: red blood cell production is controlled by EPO, a hormone released from the kidney. The main site of adult erythropoiesis is the bone marrow within the sternum and iliac crest. Each pronormoblast produces 16 mature red blood cells. As they mature, red blood cells decrease in size, become less basophilic in their cytoplasm, develop the orange tinge of hemoglobin, and lose their nucleus. The most common nucleated red blood cell seen in the peripheral smear is an orthochromic normoblast. The red blood cell membrane is a trilaminar structure containing glycolipids, glycoproteins, cholesterol, and proteins that anchor the cell and provide deformability, such as spectrin and ankyrin. Integral proteins start from the cytoskeleton and expand through the entire red blood cell membrane. Peripheral proteins are confined to the red blood cell cytoskeleton. Sodium and potassium migrate from the plasma across the red blood cell membranes in an organized fashion, controlled by cationic pumps. Deformability and elasticity are crucial properties of the red blood cell membrane, which must be able to extend its surface area up to 117% to accommodate its passage through arterioles and capillary space. The Emden-Meyerhof pathway provides 90% of cellular ATP necessary for anaerobic red blood cell metabolism. Microcytes and macrocytes represent size changes in the red blood cells determined by abnormal pathologies. Microcytes are seen in iron deficiency anemia, in thalassaemic conditions, in iron-loading processes, and with the anemia of inflammation in some individuals. Macrocytes are associated with megaloblastic processes, liver disease, high reticulocyte counts, and chemotherapy. The observation of polychromasia on a peripheral blood smear indicates accelerated erythropoiesis. Hypochromia is a color variation in the red blood cell determined by lack of hemoglobin synthesis. Sickle cells are observed when hemoglobin S is part of the hemoglobin component. There are two types of sickle cells, irreversible and reversible. Spherocytes are seen in hereditary spherocytosis, in autoimmune hemolytic anemias, or as a part of red blood cell senescence. Target cells are seen in any condition affecting hemoglobin function and in liver disease or other processes where cholesterol is loaded in the circulation. Fragmented cells occur as a result of membrane loss and may be seen in heart valve disease, in burns, or in conditions where there is a predisposition of thrombi. Ovulocytes can be seen in thalassemic processes and in megaloblastic anemias in which macroovulocytes are seen. Elliptocytes are seen in iron deficiency anemia, hereditary elliptocytosis, and idiopathic myelofibrosis. Acanthocytes are red blood cells that are smaller and possess uneven, thorny projections. Howell-Jolly bodies are DNA in origin and seen in conditions of accelerated erythropoiesis. Basophilic stippling is RNA in origin and is seen in lead poisoning and accelerated erythropoiesis. Heinz bodies are formed from denatured hemoglobin, usually from patients with G6PD deficiency. Siderotic granules or Pappenheimer bodies are iron in origin and seen in iron-loading processes or in patients who are hypertransfused. Review questions. The primary function of erythropoietin is to stimulate red blood cell production and maturation. Iron deficiency produces microcytic red blood cells. Characteristics of the red blood cell in stages of development are nuclei that are baseball round, immature cells are larger, N-to-C ratio decreases as the cell matures. Heinz bodies originate as a result of denatured hemoglobin. Iron deficiency anemia results in elliptocytes. Target cells may form as a result of excess cholesterol taken on the red blood cell membrane. Hypochromia is used to define a decrease in hemoglobin content of the red blood cell. Normal red blood cell lifespan depends on deformable red blood cell membrane, appropriate hemoglobin structure, and osmotic balance. A key morphologic feature of the nucleated red blood cell stages is the baseball round nucleus. The red blood cell protein that is responsible for deformability and flexibility of the red blood cell is spectrin.